Hi, everyone. It's time for Back to Clinical, 1K Behavioral Health Unit. I'm Mary Carls, and I will be your clinical instructor. And I made this video in order to, well, really shorten up our orientation. The time that we spend together is really quite limited. And this will give you a chance to think about some very important aspects of clinical on a behavioral health unit, which is a specialty unit, so very different from a med surg unit or a unit on the, a nursing home unit. So we'll go through the slides and talk about and think about things that make the behavioral health unit very different and unique and help to prepare you for your clinical experience. So, welcome to Behavioral Health Services, and the unit is located at Aurora Sheboygan Memorial Medical Center, and it's on the first floor, so the unit is 1K. The phone number is 451-5510, so that number is important for you to know in terms of in case you need to call in sick or if you're running late, or perhaps you forgot your stethoscope and left it in the clean utility room where we do our charting, then perhaps the staff can set it aside and make sure that it doesn't get lost. So, a valuable number. The following are some helpful hints to keep in mind on a mental health unit. So we're going to be looking at just some very specific things that make this unit different. So safety is the most important aspect. We always need to be looking around and aware of potential safety hazards in the environment. They really do a good job, and over the years, things have continued to change as far as getting rid of safety hazards on the unit, but no unit ever will be 100% foolproof. So we always have to be alert to things that might be dangerous for the patients in terms of suicide or self-harm. So we really need to take action to correct problems, even if it's just calling a problem to a staff's attention. And, maybe there isn't anything they can do about it, but perhaps there is something they could do. It might even be something as small as picking up a paper clip from the floor. So if you're in med surg or in a nursing home, if you see a paper clip on the floor, if you're really busy, you're probably not going to think twice about it, and you may just even walk past it. But on the mental health unit, anything like that, sharp metal, paper clip, pen, sometimes medications might even fall out of staff members' pockets. Students have found in the past, a couple of Motrin lying on the ground, or again, a paper clip, things like that. So we have to be really careful and make sure we pick those things up. A paper clip, you might think, well, what can you do with a paper clip? But you can straighten it out, and then all of a sudden it's made of metal. It's something a patient could use to cut themselves with, or they could even use it as a weapon towards somebody else. The other thing we really need to think about is being alert for the smell of cigarette smoke. There's a pretty strict visitor policy. However, there are still times when visitors are passing contraband on to patients and give them lighters, matches, cigarettes. And so if we smell smoke, we really need to make sure that we call that to staff's attention. As a student, I do not expect that you will be the one to go down and confront the patient and conduct a room search and find the contraband, find the lighters, matches, and cigarettes. Certainly let the staff know immediately, and the staff will deal with it. It might be a good learning opportunity for you to tag along and see how the staff handles that type of a situation. But it is truly not up to you to handle that situation independently. So basically, use your critical thinking and observation skills to determine if something is potentially hazardous in the environment. So there are new things being discovered every day. I just found out not too long ago that a patient actually discovered that there is a way in which locked rooms, so rooms that are not occupied, would be kept locked. So there's no patient in the room, there's no reason to keep the room open, the door is locked. Well, apparently there was some trick to working the handle so that that door would actually open. And then if staff members are not checking those locked rooms and there's linens on the beds, therefore that would be a setup for a patient to possibly commit suicide or, commit some form of self-harm. So that was a really great thing that that patient told staff, that there is actually a way to maneuver the door handle to kind of like break the lock open. So there's always something that we have to be alert for. Plastic bags, gloves, and sharps are not disposed of in client rooms at all. The other thing that's not in client rooms is there's no gloves. Usually there's a box of gloves, there's a sharps box, there's alcohol gel, for your hands. None of that is going to be in the patient rooms for safety reasons. And we don't even dispose of certain things in the patient rooms. So it's definitely a big change from a typical unit. So those types of items are disposed of in the nurse's station or the medication room or pretty much any place behind closed doors. Of course, sharps have to be disposed of in a sharps container, and on the unit they have a sharps container in the back of the nurse's station, and then there's also sharps in the medication room. So that would be the only place to dispose of those items. But gloves, we're so used to taking off our gloves and throwing them away in the patient's garbage. We cannot do that. They have to be disposed of behind locked doors where patients don't have access. And even that includes the wrapper from hospital slippers, so the plastic wrapper, and then the plastic wrap on food items. So a patient might get a snack delivered to the nurse's station. Before we can bring that snack to the patient, we have to take off the plastic wrap because that is a potential choking hazard. So all kinds of things to think about that you don't usually think about. Medication wrappers need to be disposed of in the med room or in the nurse's station, again, behind locked doors. And there might be some medication wrappers that require the black box for hazardous med waste disposal, such as the back part of the nicotine patch that you peel off the patch. There's a special black nicotine box in the medication room, and the wrapper from the nicotine gum also needs to go in that black box. If you're not sure about something, where to throw something away, just check with staff or your instructor. Soda and caffeinated drinks are not supplied by the unit. Patients can order soda or coffee on their menu, up to 3 caffeinated drinks per meal. Cans are not allowed on the unit at all, so if dietary does make a mistake and happen to send up soda in a can, we would have to pour that soda into a cup and give it to the patient. We cannot give them a can. That would be a definite safety hazard. So 3 caffeinated beverages per meal. Yes, that's quite a bit of caffeine. That's 9 caffeinated beverages a day. So if you notice your patient, just as an aside, if you notice your patient is ordering 9 caffeinated beverages per day, and they're asking for their anxiety medication quite frequently, they're complaining of anxiety, they're having trouble sleeping, then that might be a good teaching point for you. So just something to kind of think about. We do have decaffeinated coffee, water, decaffeinated teas, and some juice that are available on the unit. We really try hard not to give out a lot of juice because we really need to have juice available in case somebody has diabetes and they become hypoglycemic. So we are not allowed to give multiple juices to patients, such as taking a large styrofoam cup and filling it with juice. We can't do that. So we have to be kind of a little bit sparing as to giving out that juice. But the coffee machine on the unit in the little kitchen area only has decaffeinated coffee. We are discouraged from calling down to the kitchen to order soda for a patient, but if there's a therapeutic need, we can do this. And usually the unit clerk will tell us that if a staff member calls down, and that would include us as students, then it just carries a little bit more weight than if a unit clerk calls down. So there might be a time when your patient perhaps is nauseous, but they're not nauseous enough to get their Zofran or Compazine, but they're just feeling like a little bit of white soda would help. Then yes, we can call down. That is a therapeutic need. We can call down and get that delivered to the unit. Families are not allowed to bring in soda onto the unit. As far as meals, most patients are using metal silverware in the dining room. Some patients decide to eat in their room instead of the dining room. We, of course, encourage people to be in the dining room to socialize with others, and it just creates more of a family type, normal type atmosphere. But if a patient is not feeling well, maybe they're physically not feeling well, or they're hallucinating, or they're manic, and they just would be overstimulated by the dining room, then we certainly do allow patients to eat in their room, but then they are not allowed to have any utensils if they do this. So the nursing assistant will be in the dining room monitoring the trays, and if a patient is taking a tray to their room, the CNA is taking all of the silverware off of the tray and not allowing the patient to take any of that. We cannot even give them a plastic spoon. There may be some kind of an alternative utensil offered to them. We'll have to see what's available on the unit this year. There's a policy about patients using pens and pencils on the unit. Only the small golf pencils may be loaned to patients. No pens are allowed on the unit. The only exception is that when you have a patient sign a medication consent form, they can use a pen under your direct supervision, but then you get that pen right back from them. You don't walk away from them and come back. You stay right there while they're using the pen and get the pen from them immediately after they sign their name. The activity staff may give out colored pencils or markers also, and usually if they do give out colored pencils, they are again golf-sized. Research has shown that a golf-sized pencil is not going to reach a vital organ in case somebody were to try to stab somebody with a pencil or stab themselves. So that's the rationale behind the golf-sized pencils. Don't ever wear a stethoscope around your neck. Carry it to the patient room and put it in the nurse's station or with your belongings when your vital signs are completed. Don't carry it in your scrub pocket all day. Just truly carry it there to the patient room and back and put it away right away, because it may sound kind of strange, but by leaving it hanging out of your pocket, a patient can grab that. You can just be walking down the hallway or standing in the hallway. A patient could grab that out of your pocket, and then now all of a sudden they have a weapon. So we just have to be really careful to minimize, that would certainly be something that would be out of the ordinary to happen, but we want to minimize any opportunity for harm to take place on the unit. Don't carry scissors or forceps or anything else that might be sharp in your pocket. You can have a pen light. That would be fine to assess patients' pupils if needed, but nothing that is sharp at all. So take all your med-surg sharp stuff out of your pocket and leave it at home until you have your next med-surg clinical. Don't take scissors with you to cut the nicotine or any other med packages. We're going to be cutting those packages in the med room and leaving the scissors in the medication room. Just lots safer than a patient possibly grabbing it off of your computer. Even if you're standing right there, you'd be surprised sometimes what patients may do if given the opportunity. So you might see staff taking scissors with them, and that is fine. But as students, I really don't want you taking scissors with you. Anything we need to cut, we'll use scissors in the med room and leave the scissors where we found them. Always want to be aware of your own personal safety at all times. And again, I'm going through this, I'm hoping you're not scared already and thinking, oh my goodness, what kind of a place am I doing clinical? I'm just really talking about the most unusual occurrences that could possibly happen. These things certainly don't happen on a regular basis. But if you think about and plan for things that could potentially happen, and you're aware and alert of your surroundings at all time and taking measures to protect yourself, then nothing's going to happen. You're going to have a very fine clinical orientation and clinical session. I have never had a student be harmed by a patient, but I truly think that in order for that to continue to happen, you do have to take these safety measures really very seriously. So be aware of your personal safety. You don't just walk down the hallway like you're walking through the grocery store. You have to be aware of if somebody behind you is somebody to the side of you, who's in front of you. Just always be aware of who's around you. And if a patient looks like they possibly could be angry, agitated, hallucinating, it may not even be a patient that you are taking care of. Most patients aren't in their rooms all day. People are out and about. They're out into public areas. They're in the hallway. They're in the television lounge. They're in the group room. So people aren't just in their rooms. People are in the hallways and out in public areas. So you really have to be very aware of what's going on around you. And then also not to let yourself ever get backed into a corner. So you don't ever want to be in a position where you're in the patient's room and you're next to the window and the patient is near the door and they can leave, or they could block you from leaving. Not that they could leave, but they could actually block you. They could stand in your way. They could close the door and you can't get past them. So very important to just kind of always think about your safety and leave yourself an out. Always trust your gut instinct. Take someone else with you if you're not very comfortable. Let me know right away. Let me as your instructor know if your patient is sometimes they might be a little different from what we heard in report, or when we're there for preclinical prep for my lifespan students. We're there on Monday afternoon. Maybe by Tuesday morning something has changed and they're not doing as well as they were on Monday when we got information about them. So if you're kind of uncomfortable by the way your patient looks, by the way they're acting, or things that they're saying, let me know right away. I might even need to change an assignment depending on what's going on. So somebody that maybe was appropriate to work with on Monday, maybe they're not appropriate all of a sudden on Tuesday, or maybe even they were fine to work with on Tuesday, but now something again has changed and they're not appropriate for you to work with on Wednesday. So you need to tell me things like that right away. There might be times when somebody is they're okay to work with, but they still might make you feel a little bit uncomfortable, such as the person that has schizophrenia and maybe they're delusional and hallucinating. So it's always okay to take somebody else with you. And it's always, again, important to sit with a patient. The patient is near the window and you are always positioned near the door. Leave yourself an out. Leave doors to rooms open when talking with your patients, or meet with them in a public area on the unit. So you might be thinking, well, that isn't very respectful of confidentiality and the very personal things that they might want to talk about. But truly, that is a norm on the unit. The physicians mostly talk to the patients in their rooms with the door open. Very rarely, sometimes you'll see the door closed by other professionals. Even the mental health counselors sometimes close the doors. But truly, the safest thing to do is to leave the door open, or meet with them in a public area where there's other people around. Of course, if they're in the TV lounge and there's multiple patients in there, that's not the time for you to be carrying on a very in-depth conversation about their thoughts, feelings, stressors, suicidal ideation. You want to do those things kind of privately, but just make sure that you're not putting yourself in a position where the patient can block you and prevent you from getting away from them if that the case needs to be. And just going along with that, again, I don't mean to scare anybody because I truly have not had anybody get into difficult situations. But if you do sit with your legs under a table, pushed all the way under the table, like the chair is pushed all the way in, then if you do have to leave quickly, it's going to be kind of difficult for you. So you have to take the time to push the chair out and then get your legs free and stand up and move. And that just could make it difficult to get away from somebody if you need to. The other thing is not sitting on the floor. just an example, once a student I found sitting in the hallway next to their patient who was sitting on the floor, and it seems like a good thing to do to get on the patient's level. The patient was on the floor, so the student thought, well, I'm going to sit on the floor here and talk to them. But honestly, again, if the patient all of a sudden were to change and become combative or suspicious of the student or say something that was threatening or provocative in any way, then it would take the student probably, a couple seconds extra than you'd want to take to actually be able to uncross your legs, stand up, and move away from the situation. So truly, truly, don't sit on the floor. Don't sit with your legs under a table, and just make sure you have easy access to leave the patient in a moment's notice if the condition warrants. And again, not likely to happen. I'm just telling you all of the things, the possible worst case scenarios, so that you're fully prepared and so that everybody stays safe. Very important to ask direct questions when a patient has suicidal or homicidal ideation. So sometimes patients come in and we hear that in report. Sometimes we hear that they have homicidal ideation towards nobody in particular. So that's a little bit concerning. I might not even assign you somebody like that. It just really kind of depends. If I know the patient well and I know they have a history of being fine to work with and not being ever combative, they may just have those thoughts, but they never act on them. But if they have homicidal ideation towards nobody in particular, that's a little bit concerning, more so than the person who has homicidal ideation towards somebody in particular, such as their ex's new spouse or something like that, or their boss. They may have homicidal ideation towards their boss or a neighbor. Then we know those people aren't on the unit, so then we can maybe just feel a little bit more comfortable with that. But the more specific information we have, the safer we'll be able to keep everyone. So if we know if they have homicidal ideation, who is it towards? How strong is that feeling? We can always ask people to rate things on a scale of 1 to 10. So how strong is your suicidal ideation? How strong is your homicidal ideation? And just if the patient really feels like they would do something to act on those thoughts or feelings. So suicidal ideation, we'll talk more about that when we actually meet in person, but it really is very important to assess if a person feels like hurting themselves. How strong, again, those feelings are on a scale of 1 to 10. Are they looking around on the unit to find things to hurt themselves with? If they had the means right now, would they follow through? Are they thinking about doing something once they're discharged? Do they have a plan? Do they have a plan here in the hospital? Do they have a plan for at home? Very, very important to really think about all those aspects of suicidal ideation. And truly, the best way to assess that is just to be very open and honest with the patient, and of course very concerned. If you act in a very concerned manner, not judgmental, patients usually are very open and will talk about their suicidal and their homicidal ideation. Because truly, if they're in the hospital, they're usually at a point, unless they're there involuntarily, most of the time they're at a point where they're just really struggling with those feelings and they don't necessarily want to follow through with them. The other thing to think about, if somebody is having any kind of hallucinations, then the voices are telling them either to hurt themselves or to hurt somebody else, particularly the nurse. So we always want to ask specific, direct questions if we hear that the patient is hearing voices. So we always want to say, are the voices telling you to do anything? Are the voices telling you to hurt yourself? Are the voices telling you to hurt anyone else? Are the voices telling you to hurt your nurse? I know it really sounds kind of, oh my goodness, really? You have to ask all that? And yes, you do. In order for us all to be safe, very important to really to delve and to ask all those questions. We also never want to leave a patient alone who becomes acutely suicidal or homicidal. Get staff help immediately. And it doesn't mean that you have to put yourself in harm's way, but you do need to keep your eyes on the patient. So if the patient says they're feeling homicidal towards all staff right now. Well, then you're going to back away from the patient, but you're going to kind of keep your eye on them and flag somebody down in the hallway. There's always somebody in the hallway that you can flag down for assistance. So very important. If somebody tells you that they're feeling like committing suicide, their feelings are very strong, they're looking around for something to do, or they've even taken a golf pencil and scratched themselves with it, then we need to intervene immediately, and you need to get some help in there. Preferably your nurse or possibly even a mental health counselor. But again, keep your eyes on the patient. Don't just leave them alone and say, I'm going to go get somebody. You're going to keep your eyes on them, even have them come with you to the nurse's station if they're willing to do that, just so that we want to make sure that they are safe and we're not leaving them alone. They have some new rules for 2019, and I actually think they're quite really good rules. And actually, these are things that I've encouraged the students to do anyways. So I'm really pleased that the staff are now doing this on the unit. So if the patient is in their bathroom during 15-minute checks, because we're doing 15-minute checks on everyone every day that we're there for clinical. So if a patient's in their bathroom during a 15-minute check time, we are to ask through the door if they're okay. Now, the doors aren't floor-to-ceiling doors anymore. They are made of like a foam, and they are Velcroed through to the wall, actually. So we can look through so there's a big space at the bottom and then kind of at the top. So the patient isn't completely hidden when they're in the bathroom anymore. So we can visualize their lower extremities through the partial door. You know, if we see their legs and we see they're moving around, it's still probably a good idea just to say, you know, hi, I'm Mary. I'm your student nurse. I'm just doing my 15-minute check. Everything okay? And just to hear back from them. If you don't have a response from them, then we are to open the door, even though that is a kind of a breach of their confidentiality or privacy. It's okay to do that. If we say, are you okay? And we don't hear any response, even if we see their feet through the bottom of the bathroom door, we need to open the door. So a very important change that they just recently instituted. And we are assessing suicidal and homicidal ideation every shift and asking patients to review their safety plan and list of soothing interventions. So when they come in, they are asked to start working on a safety plan for themselves and to come up with a list of things that are helpful to them, that are soothing when they are feeling distressed. So we always want to kind of review that with the patient. We are no longer asking the patient for a contract for safety. So we used to say, and some of you, if you've done clinical there before or have work experience there, we would always say, can you contract for safety, which is an agreement not to hurt yourself or anybody else. And we used to chart that. We are no longer using that terminology. We're not asking the patient to contract for safety, but yes, we are absolutely assessing suicidal and homicidal ideation. So we are still going to be asking questions like, are you feeling suicidal? And do you have a plan? Do you have a means to the plan? Are you looking around here in the hospital for something to do to hurt yourself? So, and again, homicidal. So asking if they're feeling like hurting another person, either somebody here in the hospital or somebody on the outside. So we are just not doing that contract for safety. And of course, if you're not familiar with that, that's not going to be a big change for you. But having that relationship with the patient, developing a rapport, and asking those pertinent questions is a better indicator of and a better help to suicide prevention than a contract for safety. Another really great change to safety on the unit. There will be signs now posted on patient rooms where medical equipment is in use, such as walkers, canes, IV poles, or CPAP machines. And those items, there's certainly safety hazards, but some patients need those for therapeutic reasons. So staff awareness is really essential. CPAPs need to be removed from the room as soon as the client is awake. And I think by having having a specific sign posted outside the room saying medical equipment that should alert everybody to noticing if that CPAP is in the room or not, or if it's, if it's been put in the patient belongings room for storage during the daytime when they're not sleeping. Many times in the past, it would be 10 or 11 o'clock in the morning and the CPAP would still be in the room, and I would happen to be in the room then with a student and realize that that's still there and ask the student to remove it. So I think this is a much safer way to manage, especially the CPAP machine, because of the cord and the tubing. But IV, if somebody is on IV therapy, then the IV pole certainly has to stay in the room. Canes, walkers, things like that that people need for ambulation, of course, we're not going to be removing from the room, but it's just good to be aware that patients have those things since they can be potentially hazardous. The staff will also be checking all unoccupied rooms every hour, and all those linens are removed from those rooms. Again, getting back to what I had mentioned previously about a patient discovering that by kind of manipulating some of the door handles a particular way, they could open rooms that were locked. And so again, very dangerous for a patient because a staff member is not going to necessarily be rounding on those rooms, or they didn't used to in the past. Nobody would ever go in those rooms if it was unoccupied. So if a patient was in there, they could be doing anything self-harm. And actually, I believe that there was a suicide not in Sheboygan, but in another Aurora facility in another city because of this very similar issue. So now staff are checking those unoccupied rooms at least every hour, and then there are no linens in there, because if a patient did sneak in there and somehow manipulate that door handle, sneak in there, and linens are in there, you could easily be ripping linens and making something to hang yourself with. So again, a really great change in safety procedure. Another new thing this year is a timer is going to be set at the nurse's station for 15 minutes when a patient uses the shower located in the south hallway, which incidentally is very close to the nurse's station. When the timer goes off, staff need to knock on the door and make verbal contact. So if that was your patient in there, then I would expect you would be able to knock on the door and again just say, "Hi, it's Mary. I'm your student nurse. How's it going in there? Do you need any help?" Whatever. If there is no answer, again, you have a key. We need to enter the room. So as long as if we hear back verbally, the patient says, "Yep, I'm almost done. I'm fine," then that's fine. So again, really some great changes to safety. The other thing we have to think about is really maintaining a calm, professional demeanor on the unit at all times. And you might think, well, how is that really part of safety if we have patients that have bipolar disorder and they're in the manic phase and we are out on the unit and we're overstimulating, we're talking and laughing and sometimes just extra bodies on the unit can be a little overstimulating for certain patients. So if we're, just being louder than usual or anything like that, we really can stimulate the milieu a bit, and then maybe patients might not keep in the best behavioral control. So very important for us to kind of be always calm when you're out on the unit, avoid whispering or talking and laughing loudly. If you're in a small group, it's not that you can't talk to each other, but just try not to huddle in a little group and be whispering to each other in the hallway, because if a patient is paranoid, they're going to wonder what in the world you're talking about. Also, very, very important and very, very hard to do is avoid laughing when a psychotic patient does or says something funny. There are patients that sometimes that will say things that truly are funny. They're humorous, but we cannot laugh. It just isn't professional. It's not appropriate. Sometimes it actually makes their illness worse, especially if they have mania. So we have to be really careful of that. When we have orientation together, I will tell you a couple of examples that it was very difficult for students not to laugh. But again, we have to be really careful of that. So we have to put on our neutral psychiatric nurse face when we're out on the unit and truly try to not overly respond or respond with a great deal of emotion when patients say things that are odd, unusual, or funny. So that might be a challenge for some of you. If you do notice or hear anything that you think is unusual or unsafe, just let staff know immediately. Sometimes students are great at picking up on things, but you may or may not know that that's something that should be reported. And again, we can talk more about that when we're together, like what specifically would constitute something unusual. Well, I'll give you one example. A patient once heard a patient on the phone. Now, patients don't have phones in their rooms. There are two phones in the hallway, one right by the med room, one right by the nurse's station, and then the other one is in a lounge on the north wing. Yes, the north wing has a small lounge and there's a phone in there. It's a little more hidden. But the phones in the hallway, you can easily overhear somebody's conversation. And again, privacy, well, safety is again the highest priority. So sometimes privacy isn't always, I shouldn't say it's not respected, but it's just that it's not a very private environment for patients to be making phone calls. So we do overhear conversations. And if you overhear something that you're concerned about, please let someone know. We can't just say, oh, that's a phone call that's private. I can't respond to that. Yes, you can. So a patient once was talking on the phone to somebody. They were being discharged that day, and they told somebody to make sure there was a cold case when they got home. And the student came to me and said, what's a cold case? And I was kind of like, well, I was thinking to myself, it's probably a case of beer, but I wasn't positive. So I said, why don't you go ask the patient? Just tell them that you overheard them in the hallway, and they were talking about a cold case, and what would that be? And the patient did tell the student that yes, it was a case of beer. So that was very important information because the patient had issues with alcohol and they were going through detox, and the patient did not believe that beer was alcohol. And so they thought, hard liquor, I'll just stay away from hard liquor. Well, that's a really good teaching point. And very important for us to know upon discharge that this person is planning on drinking. So the other things that might come up would be there are many times young patients. We have a lot of sex trafficking in our area. So if you overhear a conversation and you think perhaps a young patient is in danger of being sex trafficked, we certainly can bring that to the staff's awareness, and we'll all do our part to try to encourage that patient to perhaps make different choices. The other issue that does come up sometimes is that patients are often overheard making plans to get together after discharge or even possibly live together after discharge. People are adults. We can't make decisions for them. However, if we overhear that, we certainly can encourage people to not to do that and just really to focus on their own recovery, their own strengths, and their support systems, because many times those situations don't always work out very well. And I'm not even talking about male-female relationships. I'm just talking about even people just creating friendships and then wanting to live together after discharge. So, again, they're adults. We can't stop them, but if you overhear something like that, it's perhaps something the staff might want to address with them. Don't congregate in front of the unit clerk's desk. It kind of comes to a V. And even though we're not letting a lot of people in and out of the main doors to the unit anymore, she still needs to have a clear view of who's coming and going from this locked unit at all times. So that policy changed about a year ago, where we are no longer able to use the main front doors to come onto the unit because they had way too many escapes. So the person hitting the button to let somebody on or off the unit is way far away from the actual door. So, that part didn't work out very well, and it was very easy for patients to elope off of the unit. So we really So even though we're not letting a lot of people in and out of those main doors, that unit clerk still needs to keep her eye on that door, because sometimes patients even can, if they push on that door long and hard enough, they can actually open the door. It's only held by a beam, so it's not an actual physical metal lock. It's a beam. So very important not to congregate like right in front of that unit clerk's desk. Also, we're not going to ever be congregating in the nurse's station or using the computers in there, except in the morning before a report. You might be able to go in the back room of the nurse's station and use the computers back there. But after report, once we're out on the unit, the doctors that are assigned on that unit, those computers are reserved for them, and so we are not back there. Once the doctors leave, then I usually go back and I will sit down and look at your charting and things like that. But otherwise, and maybe, once in a while, one of you might be able to sneak back there, but not during the time in the morning when the doctors are there. So, but you you definitely will want to enter the nurse's station to speak with your nurse. So don't feel like, oh, I can't go in the nurse's station. My nurse is in there. I've got something important to tell her. Absolutely go in there and tell your nurse something. But it's just that we can't just hang around the nurse's station. It's really small, not very much room to move around there, and there's lots of people coming and going from that nurse's station. It's a little bit chaotic in there sometimes. So I will be giving you a set of keys to use during clinical. Don't set them down anywhere, even for a minute. So at the end of the day, don't set them down and kind of turn your head while we're kind of still on the unit out in the hallway. Just keep them in your pocket at all times. There was one time where a student was going into the kitchen to get her patient probably some tea or decaffeinated coffee, and actually left the keys in the lock. So be very, very aware that that's a huge safety hazard if the keys were to be, in the hands of a patient. So don't set your keys down. Keep them in your pocket at all times. I give them to you when you arrive in the morning, and I collect them at the end of every clinical day. So just again, keep those in your pocket. We don't give badges out any longer. We used to years ago. There are some areas on the unit where you just can't have any access unless you have a badge, because they have badge readers on several doors. So I or the staff will assist you to access those restricted areas of the unit. So it's just that you can't get to certain places on the unit by yourself. Professional behaviors. So confidentiality is of utmost importance, and it's expected this would be maintained at all times. Let the instructor know if you know a patient personally, and that patient would not be assigned to you. So for my lifespan students, I will be giving you a list of patients to pick from when we meet on Mondays. And if you even think that a patient, like you remember a name possibly that you graduated from high school with, or you think you know that person, it's probably better not to take that person. Unfortunately, the intermediate students, you really won't find out who that patient's identity is until the next day, until Tuesday. And but if that was a patient that you knew personally, then I would have to quick change that assignment on Tuesday morning. It's just very important that we do that. Be aware that also there might be issues related to media coverage of some patients' behaviors, and these should not be discussed outside of the clinical setting or posted to social media sites. So very important. There were times when patients made very dramatic suicide attempts, and there it was right on the front page of the Sheboygan Press, or that a patient was discharged from the hospital and went to a local pharmacy and actually drank some alcohol, went to the pharmacy and pretended they had a gun and was trying to rob them of narcotics. And so you can't open the paper and say, oh my goodness, I just discharged that person this morning. So just really important to kind of be aware that there are some things that do end up in the regular media and social media. Also, part of professional behaviors is when you observe a group on the unit, and I would love you to observe as many groups as possible because it's a great learning opportunity. But your role really is to remain silent and simply observe. Don't share your own personal information or feelings with the group unless the group leader asks for student input or to role model healthy coping. So if the group leader says, students, tell everybody what you do to cope effectively with your stress. Then it would be okay to say, I ride my bike, I watch a funny movie, whatever it is that, that you do to cope. But otherwise, you're not interjecting your own thoughts, feelings, relationship issues, anything like that. Just remain very professional and keep appropriate boundaries with each other when you're in that room. Because I know when you're students, you develop wonderful rapports with each other, and you're just really good friends, and you're so supportive of each other. But you have to be very professional when you're, and not let those types of things show when you're out in the public area on that unit. So professional and keep those boundaries. Honesty is important when you're interacting with patients, but you should not be self-disclosing personal information. So you really don't have to tell the patient anything personal about yourself. And if I were you, I would not tell them like where you live, what town you live in or what city. They really don't need to know that information, and who knows, they may be thinking that they're going to try to look you up on social media or something, because I have had that happen before. And if you wear, like I wear a wedding band, and I can't, if a patient asks me if I'm married, I'm not going to lie. I've got a very traditional wedding set on. So I might just say, yes, I'm married. Tell me about your relationships. How are your relationships going? So turn it back on them. Do not continue the conversation focused about yourself. Some patients will try to do that because it's easier to talk about you and your, role as a student or your education or your relationships or whatever than it is to talk about their own issues. And they're in the hospital to talk about their issues and to try to get better and to try to strengthen their coping mechanisms. And they're not going to do that if they're focusing on you. So try to just flip that around as best you can and have them talk about themselves. And it's also never in the best interest of the patient to keep a secret for them, and anything pertinent for their care has to be shared with the rest of the treatment team. So there are times when the patients will say, I really haven't told anybody this before, and if they start to say, keep this secret for me, just make sure that you stop them and say, before you tell me, I just need to let you know that if it's pertinent to your care, I need to tell the rest of the treatment team. There are times, believe it or not, students have so much time to spend with their patients. Really more time than the staff does. So there are times when the patients will be very forthcoming and they'll share things with students that maybe they haven't told anybody before. And it's very important for us to make sure that we pass along anything that's really important, and just make sure we don't want to destroy the patient's trust, and so we have to make sure we tell them up front. Also, during clinical, you may wear colored scrubs if you have them. If you don't have colored scrubs, do not worry about, oh my gosh, now I have another expense. I have to go out and buy a bunch of colored scrubs. No, you don't. You can wear whatever is LTC's current uniform. Just don't ever wear all white. I don't know why anybody would, but you can wear usually solid colored pants in a solid or a patterned top. So it doesn't really matter what the pattern is, except no camouflage in any color. Even if it's pink and purple, it's still camouflage pattern. That can be triggering for people that have post-traumatic stress disorder, especially related to the military. But most pattern, you can use your judgment. Most patterns should be absolutely fine. But I always have to tell this funny story about a float nurse who came to the unit one day, and she did not know. she was going to float. So she had the scrub top on that had little chipmunks and nuts all over it, and all over the scrub top it said "Go Nuts" multiple times. Well, not really appropriate for a mental health unit, but we all had a good laugh about it because she truly said she would not have worn that if she had known she was floating, but she did not know that ahead of time. So I guess any pattern, but maybe if you have anything like that with little chipmunks and "Go Nuts," you might want to save that for another time. And again, no camouflage. And if you don't have anything that's colorful, you certainly can wear the black or black and white LTC uniform. Other areas that we're covering: personal belongings are to be kept in the staff lounge across from the dining room, and I will show you where that is, and that is behind a couple of locked doors, so you do not have easy access to this area. I will have to let you in and out of that area, so you are going to have to really be sure to plan ahead and think about things that you want with you and need with you on the unit, and other things that you're not going to need except for when you go to lunch or when you are collecting your belongings at the end of the day. So at least we are very lucky we don't have to have lockers anywhere else in the other parts of the hospital. You can keep your belongings right with you on the unit. So that includes backpacks, coats, purses, food. There is a refrigerator for you to put your lunches in. So we're very lucky that we have those accommodations on 1K. Ill calls go directly to the unit, again 451-5510, but occasionally I know that it's hard to get through because there may not be anybody sitting there. The night shift might be extremely busy and they may not even get to your phone call right away. So just don't call my office phone number at LTC because I'm not going to be there that early in the morning, or my home phone. Sometimes in the past, students have looked up my home phone and have left a message there, and I'm at the hospital quite early, so I would not have gotten that phone call. And yes, I do have a landline still, I know. But definitely you can text me on my cell phone, and the phone number is right here for you. Definitely add that into your on your cell phone as far as a contact, and then you will always have access to my phone number. Send me a text message if you're running late, if you're sick, if you have any questions or problems. That would probably be the best way for you to call in, but I'm hoping that you're not going to be sick. Snow days are usually called after clinical has started. Therefore, it's best to wait at home until LTC makes a decision on whether or not to cancel school. And sometimes they just don't make those decisions early enough for us that are, traveling to clinical. So if they don't close, if LTC is open and say now it's 6:15 and they finally have made a decision, they're not going to close, clinical is still on, but you're not going to be penalized for being late or absent due to severe weather. So then you can start out, and however long it takes you, if you live in Two Rivers and you're traveling to Sheboygan, it may take you quite a while, and that's absolutely fine. You do not get a 2 for being late for that type of a situation. Or if you live in Two Rivers and the weather there is absolutely horrible and you have an old car with bald tires, well then just send me a message and say, I just don't think it's safe for me to come. And again, I'm not going to penalize you for not being able to come because the weather is severe. So if LTC does call a snow day, then we're off for that day. If they call a 2-hour delay, then we start clinical at 10 a.m. Other areas: scan or take a picture of your CPR card front and back and submit it to the Dropbox in Blackboard before the first day of orientation. That just makes a really easy way for us to check those. And I know now they're doing, most of these are electronic. They're not even a physical card. So whatever you have, whatever electronic form you have, just submit that to the Dropbox, and that would be just fine. And just make sure that it doesn't outdate any time during the clinical rotation. Otherwise, it has to be updated before you start clinical. So very important thing to keep in mind. Same thing really with TB skin tests. Flu shots, since I'm recording this in the fall, I think the last date available for us to get the flu shot documentation to Renee Brookshin, our college health nurse, I believe is sometime in early November. I don't know the exact date yet at this point in time. So we're not going to, maybe in fall right now, we're not going to worry about that flu shot right away. And I will hopefully have more information to tell you when we meet in person. But the TB skin test also, again, that if it's going to outdate any time during your clinical rotation, then you need to get it updated before clinical starts. So that's just the safest way to handle that. And it has to be on file with the college health nurse. The dosage calculation exam has to be passed at 80% before we pass meds on the unit, and every course calendar is going to have specific due dates. And usually we try to give you enough time to take a retake in case you need to take that second exam. But of course, that first exam is what counts in your grade point average. The Aurora orientation must be complete prior to our orientation date, and the 3 forms need to be turned in during the orientation session. And so there's an orientation checklist, a confidentiality, and a minimum necessary of use form. And you should be able to get those off of the Aurora orientation site. I will be having you update your phone and your email on my list to make sure they're correct. So I'm going to print off a roster and have you double check that. And it's really a good thing we do that because sometimes LTC doesn't always have your correct cell phone number on the roster. I was sending a student text messages once, and then she never answered. And then several days later, when she saw me in person, she said, "Why are you texting my husband?" And I said, "That's because that's the only number that we have for you in our system at LTC." So anyways, we were able to correct that. So I will pass around a piece of paper that you can update. So we're going to make sure that I'm not texting a significant other instead of you. So I will also talk to you about my office hours, but honestly, anytime you need anything, just shoot me an email, send me a text message. And even if it's not a specific time that I have office hours, if I can, I will certainly make time to meet with you if you need any help with anything. Another area is our dress code. Again, we talked about the uniform already, but now we're thinking about hair. So even though you're on a mental health unit, you're not on a med surg unit, and you're not going to be doing as much physical care with people, you still want your hair to be tied back and not not hanging down. So just make sure you still do the same thing that you do with your hair in a med surg setting. Jewelry, piercings, fingernail length, gum chewing, avoid any perfumed lotion, soaps, and body sprays. So all those types of things we should still be abiding by, and just review the dress code or ask me if you have any questions. Really important not to wear any type of necklace, nothing around your neck. And I know sometimes students have certain pieces of jewelry that are really sentimental that they're wearing around their neck, but I would absolutely hate for you to be hurt, or if a patient grabbed it and broke it, I would really hate for that to happen. So just for safety reasons, it's always best not to wear anything around your neck, no necklaces at all, certainly no dangling earrings, even though once in a while I do see some of the staff wear necklaces and I do see some of them wear dangling earrings, but honestly, it is a risk, and it's really something that could result in their harm. So daily responsibilities. So you're going to be doing a physical assessment, a little bit of a physical assessment. You are not doing a head-to-toe physical assessment like you do in med-surg, and you're not doing the patient profile database on every single patient. So we're doing some minimal things like their blood pressure, their manual pulse, never get the pulse off of the machine, their temperature, respirations. I tried to combine those two. Temp, respirations, pulse ox, and then we're assessing their skin, their pain assessment, and any other aspects of physical assessment as needed or tolerated by the patient. So again, we're not doing that full head-to-toe physical assessment, but if the patient has issues with diarrhea, then we're doing a GI assessment. Or if they have asthma and they're using an inhaler, then yes, we're going to be doing a respiratory assessment, but we're only doing what is needed or tolerated by the patient. If the patient is paranoid and they say, get away from me, I don't want you listening to my lungs or my abdomen, well, then we're not going to listen to their lungs or their abdomen. Pain assessment, certainly we use the same 1 to 10 scale as they do anywhere else. Just to say a word about integumentary, when a patient is admitted, the staff does a full skin assessment. So we are not needing to do that. It's done with 2 staff members present, and there's actually a script that the staff member needs to read from. It is very, very specific, and of course allows for as much privacy as possible, because we are asking the patient to remove all of their clothing and we are inspecting all of their skin. So we do not need to be repeating that. What we need to do, though, is after that initial skin assessment that the staff does on admission, we need to follow up on any of those areas of concern that the staff have outlined. So if they notice some abnormalities on their skin, a cut, a rash, some self-cutting, a lot of patients self-harm, and they may have some self-inflicted cuts, then we need to follow up on those areas, and we can always ask the patient if they have any new areas of concern on their skin. And again, just you're doing it in a very professional, matter-of-fact manner. So I just wanted to make sure that you didn't think that you have to do a full head-to-toe skin assessment on the patient every day. No, we don't do that. They just do that once in a very, very specific manner. The mental status assessment, we're always going to be doing that, but don't ever chart the patient is within defined limits, because if they're on the mental health unit, even if they're being discharged that day, there usually is still something, some depression, some anxiety, maybe some paranoia. There still will be abnormalities that you're going to note. So we'll go over that a little bit more when we talk about EPIC charting, but just make sure that we always do that every day. That's a very much of a daily responsibility, but don't say the patient is within defined limits, because then truly they should not be on the mental health unit. We might be doing other specialized assessments like the CEWA, which is the way that we assess somebody's alcohol withdrawal. There is an opiate withdrawal scale that we use if they're withdrawing from those drugs. AIMS scale to see if they have tardive dyskinesia from their antipsychotic medications. There's a self-concept tool, Beck Depression Inventory. Some of those we don't have to do those. Those are things that perhaps we might do if it applies to the patient or if it would benefit the patient. And the BVC scale is actually a scale that we're using to determine if somebody meets criteria for having a PRN of medication if they're feeling somewhat aggressive or agitated. So those are things we may or may not be doing. They're very specialized assessments. We also always want to encourage or assist the person with their ADLs. So most people are independent and they're fully functional physically. However, there are times when patients just need a lot of encouragement because of their paranoia or because of their depression. They just can't get themselves into the bathroom to take a shower or to brush their teeth. So we always need to be asking the patient, did you brush your teeth today? How about taking a shower? Just really encouraging people, as kindly as possible. So if somebody's really been resistant to that, sometimes it helps just to be a little bit more directive and maybe even take them their shower supplies, towels, soap, shampoo, and say, would you like to take your shower now or at 10 o'clock? Kind of give them a choice, but kind of anticipating that you're hoping they'll pick one. So it definitely making sure they do their ADLs. Don't just take it for granted that, they're just going to shower every day because everyone showers every day, or they're just going to brush their teeth because everyone brushes their teeth. Don't take those things for granted. There are many illnesses in which people don't take care of their ADLs, and we really need to help them with that. We also want to encourage or assist them with meals, noting the percentage of intake, and INO if ordered. We don't seem to have a lot of patients on INO, but we always are at least monitoring how much they ate off of their tray. Many times the CNAs will document that information as they are the ones monitoring the dining room. So, but at least if we can encourage people to eat, it's never acceptable just to say in your progress note at the end of the day, well, my patient didn't eat anything all day. Well, what did you do about it? Did you offer them something? At least if you can document that you called the kitchen, that you tried to get them something that they really enjoyed, that you offered them multiple things. There are some snacks available in the kitchen area, or even offered to call down to the kitchen for something specific that the patient feels that they would eat. It's just never acceptable just to chart that the patient didn't eat or drink anything all day. We really have to have a reason why. Maybe they're too paranoid, and that certainly is a reason, but then what did we do to try to manage that situation? How many times did we try to offer them food or fluids? We are, again, are doing suicide or behavior checks every 15 minutes. I think I mentioned that before. There is a specific clipboard, and we need to be documenting on that clipboard. What I've been doing that the staff have asked me to do since last year is I will make a copy of those sheets and give them to you, and you carry that in your pocket, and then you can mark that do your 15-minute checks and mark them on your sheet as you go along during the day, so you don't have to keep running back and forth to find the clipboard. But then at the end of the day, before you're off the unit, you have to catch up and mark all those checks on and where the patient was on the real 15-minute check sheet. So it'll be more clear when I take you on the tour of the unit, that I can show you where we usually keep that. But that's a hugely important part of your role, is to help with those 15-minute checks, because when you're doing them, the staff are not doing 15-minute checks on your patients. They are doing 15-minute checks on the rest of the patients on the unit. So that is your responsibility, and make sure that you give another student your 15-minute check sheet, the copy that I give you to put in your pocket, if you're going off the unit for lunch, or if you're going to a court hearing, or if you're going to a group that your patient is not attending. If you're going to a group and your patient is going to the group with you, that's fine. You don't need to give anybody your 15-minute check sheet, because you're right there. You're visually with the patient. So really important to make sure that you give your check sheet to somebody else if you, for whatever reason, are not going to be available for a period of time. So always assess for suicidal or homicidal thoughts early in the day. Don't wait until noon. Don't wait until it's real late in the shift. Try to do it as early as possible. But of course, it's not going to be the first thing out of your mouth. You're not going to, they're just opening up their eyes and you've woken them up and you say, "Hi, I'm Mary. I'm your student nurse for the day. Are you suicidal?" Well, no, you got to lead up to it a little bit and give them time to wake up. But try to do it as early as you possibly can. We're going to always try to encourage or assist with room cleanliness and laundry. We want the patients to be as independent as possible. So that's a huge part of your role, is to help the patient to be independent and to really foster their getting back into a normal routine and to do things for themselves. But if the patient is, say if they have bipolar and they're very disorganized, they may need some help making their bed. They may need some help with organizing their laundry, things like that. And of course, then the laundry room is locked. The patients can't get in there, so you would have to take their laundry in a paper bag and throw it in the washer for them. That part is absolutely fine, but it's just that the actual getting their stuff together or folding it, really we should let the patients be doing that. But don't think that it's your responsibility to go in there and straighten up the patient's room and throw garbage off the floor, pick it up and throw it away. And that's not, making beds, that's not your responsibility. We really try to make the patients as independent as possible. It really helps with their self-esteem. Attend group therapy sessions with your patient, again, with permission of the group leader. The only time the group leader might not want students in there is, say, if it's a very small group. Maybe 5 students want to observe group at 9 o'clock, but there's only 3 patients in there. That might be a little bit overwhelming for the patient. So the group leader may only want 1 or 2 students in there. So it varies, but most of the time, people are very happy to have you guys observe group sessions. Also, you may have an opportunity to attend a court hearing with your patient if that's applicable. So if your patient is there on a chapter and they're there against their will, they may have a court hearing scheduled. It is right on the unit. It's in the same room where we have report in the morning. You have to go with your nurse because it's through 2 sets of locked doors with badge readers, and you do not have a badge for the badge reader. So you have to hang out with your nurse, and you would definitely be with your nurse. You would not be expected to be down there in the court hearing as the staff member assigned to the patient. You would always be with your nurse. But it's a really great learning opportunity, and there are times when other patients on the unit may have court hearings, and they may be amenable to having students observe, and I may send a couple of students down there to observe, even if it's not your patient. But just remember, what are you going to do with your 15-minute check sheet? Give it to another student and make sure that your patient is being checked, because the court hearings could be 10 or 15 minutes, but it could be half hour, it could be 45 minutes. So we always just want to make sure that we safeguard our patients by having somebody else do those checks. So I'm hoping that some of you will get a chance to see some court hearings. Also, if you see the doctor going towards your patient's room, or if you're in the room with your patient and the doctor comes in, don't leave the room. I think it's very tempting for a student to say, oh, the doctor's here, I'm out of here. Stay in there, and as long as it's okay with the patient, it surely would be okay with the doctor if you stayed and listened. It's very helpful for you guys, because you will learn a lot from spending that time with the doctor. But if the patient says, I think I really just want to talk to my doctor privately today, then you would leave. So definitely try to do that, and you yourself spend some one-to-one time with your patient, encouraging them to discuss problems and feelings. It's sometimes a little challenging to find a lot of time to do that, only because there are so many people that have to spend time with the patients. The physician comes and spends time with that patient every day. The mental health counselors might be wanting to spend time with your patient. There might be other activities therapy. There might be other professionals that also are spending time with your patient. So it can be a little bit difficult, and then with all the group sessions, but try as much as you can to at least sit down and have a conversation and encourage them to talk about their feelings, their coping, what they're learning in group. You can always reinforce that, what their big concerns are for the day, and of course, if they're suicidal or homicidal, we're always talking about that too in your one-to-one time. You're going to be passing medications after discussing those with me, and what I usually do is I'll go with you the first couple times, and then I will let you pass meds independently after we check them in the med room. So you'll never be passing anything without my looking at it first. But I will go with you the first couple times, because being a mental health unit, just a little bit different. We can't leave the computer on wheels in the hallway and walk away from it. So there's extra safety concerns with passing meds on the unit. So I'll be with you to make sure that you really get that under your belt before I send you out onto the unit by yourself to do that. You always want to be prepared to act on new medication orders, because medication orders are changing usually every day. You might even be asked to obtain a consent on a written form for a new medication and to do the teaching, and that is absolutely acceptable and within your realm as a student. Observe the milieu. So some of you might be thinking, what in the world is the milieu? And that is the environment all around you. It's the whole environment. It includes everything. It includes how the patients are interacting with each other. It includes how the staff are interacting with patients or interacting with each other, because if staff are in a bad mood and they're fighting with each other or not getting along very well, that spills out into the unit, and it does affect patients. If we're all revved up and in a bad mood and we're short-staffed, then that spills out onto the patients. So that's why, again, I was reinforcing a couple slides ago about how to just maintain a calm professional demeanor no matter what's going on or what stresses you're going through. We really can't let that spill out onto the unit, because the patients feel those feelings. Anxiety is contagious, believe me. So we have to be really important about that. So anything you notice about the milieu, and it includes all the physical aspects too, all the safety aspects of the milieu. So that's something we can talk about more when we meet in person, and definitely we can talk about what the milieu is like when we're in post-conference. Provide patient teaching as indicated, individualized to the patient. So I'm hoping that all of you, whether you're in lifespan or intermediate clinical, will find topics to talk about to the patient and do some patient teaching. There's also a place in Epic to document that, but just be aware that we can't just give the patient handouts that we get off of the internet. We have to make sure that whatever handouts that we give patients truly comes from an Aurora approved site. It's also an expectation to discuss any concerns either with me, the instructor, and the assigned staff nurse throughout the day. So keep us in touch with what's going on. If you have a patient who had a really low blood sugar in the morning, I would expect to know that right away. The nurse would expect to know that right away, and then we would be able to guide you as to what interventions and assessments that you need to do to kind of follow up on that. Or say you had a patient that had sky-high blood pressure of 210 over 150. I would expect to be updated, after there's hopefully an intervention of maybe giving them some medication. What's the blood pressure now, an hour later. So I like to be told that, and I know the staff also likes to be updated on any changes. CWAS, when you're assessing people for alcohol withdrawal, and you gave them some medication because their CWAS score was really high. What is it now? How did that, how did the Ativan work for them? What is their current score? How are they feeling? How do they look to you? What's your kind of subjective assessment of how they look? So definitely keep us updated. And then also at the end of the shift, you also want to report off to your RN and just kind of give them a capsule of what exactly went on throughout the day, even though you've been keeping them updated. And sometimes the nurse might even say to you, yeah, you don't really have to tell me much. You told me a lot already of what's been going on, and I feel comfortable with what's happened, and that's fine. But just make sure that you do talk to your nurse before you leave the unit at the end of the clinical day. For charting, we're going to be, again, those suicide check sheets, the white sheets on a clipboard that includes a signature profile at the bottom of the page. So the real sheet on the clipboard, again, needs to be caught up and filled out by the end of the day, and the signature profile at the bottom. But you are carrying a copy of that, again, in your packet that you can mark on every 15 minutes, so you don't have to run to the clipboard every 15 minutes. And the clipboard is to be kept inside the nurse's station. Please never put it on the ledge outside the nurse's station, because confidential information, and we don't want patients to get access to a clipboard. So very, very important. Again, little safety feature, keep that inside the nurse's station. And then you're going to be doing computer flow sheet charting and a progress note every clinical day. And when we meet personally, I will show you some samples of previous students' progress notes that they would write every day. Other expectations, it's always a good idea to just look for doctor's orders frequently, act on them if we're able to. Hopefully care for 2 patients at least 2 days out of the rotation as the unit census allows. And of course, I always have to keep in mind if the patients are safe for you to work with. So before I even make out an assignment, I always check with the staff and make sure that I'm not giving you somebody that has a potential for violence or acting out, or their behavior would be so difficult for you to deal with. So we do try to make sure of that. So that may cut out several people that we can't work with, and it may not always be possible for everybody to get 2 patients, but hopefully we'll try to do as best we can. It would be a really helpful thing if you guys could check for medication consent forms for each psychotropic medication and have the patient sign it if it hasn't been done yet. And there's white folders that are in the nurse's station right near where the unit clerk sits. All of the patient's legal forms, including their medication consent forms, are in there. And so that would be like a 5 behavior if students were to take initiative and go in and look through those folders and make sure that all of the medication consent forms actually have a signature on them. So preclinical prep forms, one for each patient, individualized to the patient, and that is for lifespan. So every patient you have, you need to do that preclinical prep form for. And in intermediate clinical, a concept map short form, at least 3 diagnoses per week. And again, when we're together in person, I can clarify that a little bit more. And everybody always does a self-evaluation completed weekly with reflection on your clinical performance. A little bit of a virtual clinical tour, and of course we're going to take an actual tour as part of orientation, but some of this information will just be, again, a little bit useful ahead of time, and then you won't have to listen to me for as long during the tour. So again, we are not to use the main front entrance at all. Actually, if you picked up the phone and asked the staff to let you through, to buzz you through, they would probably tell you no. So don't even try. I will meet you at the back entrance of the unit, and again, I will show that to you when, if you're not familiar where that is, I'll show that to you when we take a tour of the unit. But I will always meet you in the back and let you in, because you do not have badges that allow you onto that part of the unit. And we're going to use that same process on Monday for prep for lifespan, and each clinical day I will meet you in the back entrance. There is a special procedure for visitors for allowing them onto the unit, but the staff is in charge of that. We are not going to be participating in that at all. If anybody asked you to let a visitor in or out, please do not do that. Just say that is not within your realm as a student. I don't want any incident happening of a patient trying to escape because a student let a visitor out, and we don't know what the procedure is. The staff is the one to monitor that and to maintain that. We are not allowing patients to enter the laundry room, the medication room, the kitchen, or the patient belongings room. When you go in those rooms, make sure the door closes behind you and that nobody followed you in. So make sure you just close that door right behind you, and lock all doors behind you as you leave a room. Many of the doors are in a self-closing hinge, but not all of them are. It's possible now, I think they've changed most of the locks, so it's possible that they are all self-locking, but it doesn't hurt to just jiggle the handle and make sure that the doors are truly locked. Patient belongings room is where all the patient's personal effects are stored that they cannot keep with them in their room. Patients are searched upon admission. Sharps, shoes, coats, most toiletries are removed and stored in their locker in the belongings room. If a patient needs to use something from this room, you as students are able to supervise them. So you would get the item out of this room, stay with the patient while they use it in their own, the patient has to use it in their own bathroom. And you stay with that patient the whole time, keep your eyes on them, and then you take whatever it is and return it back to the belongings room. So it could be an electric shaver with a cord for a man, or it could be a curling iron and hairspray for a female, or makeup that has, glass or mirrors in it. So people can put up on their makeup, they can do their hair, they can shave, just under our direct supervision. So that's that. The laundry room is only to be entered by staff. The patient can determine what needs to be washed and put their laundry in a paper bag. You can return the bag to the patient when their laundry is done, and you can help them again restore that independence by allowing them to fold it in their room. After using the washer, as staff, we would need to pour 1 cup of bleach in the washer and run a small hot load without closing it, and that's just to sterilize the washer between patient loads of wash, and there's nothing special to do with the dryer after use. The medication room is only accessed by the students with your instructor. Your key will not let you in no matter how hard you try. I just put a smiley face there because I know that I'm in the med room and I hear somebody jiggling with trying to put a key into the lock, and key does not work in that lock. So just knock on the door and most likely I will be in there. Pharmacy regulations also are that students can't be in there alone. So it's not me being mean to you. You can't be in there alone. A staff member might let you in if I'm not in there, but if they leave, then you have to leave too. Or if you and I are in there together, but I have to go do something, I'm going to have to ask you to leave too. I'm not going to leave you in there by yourself. And that's, again, a pharmacy rule. There's a black hazardous med container in the med room specific for nicotine. There are other ones too, and we can go over those when we take the actual tour. But again, if the nicotine patch is on a patient for less than 24 hours, it would need to be disposed of in the nicotine container. Otherwise, it just goes in the regular garbage. The backing of a new patch needs to be disposed of in that container. Don't throw paper or med cups or gloves in that container. It should only be nicotine products. And again, I believe the packaging for nicotine gum also goes in that black nicotine box. So most of the medications for the patients are in the Pyxis machine. I have fingerprint access to this, but will allow intermediate students to pull the meds once I've opened the machine, and we will always count narcotics together. I will pull the meds for lifespan students for those first couple of weeks, and then the last few weeks I would like you to pull them just because that'll help you get ready for intermediate, but I will be standing right there while you're pulling things out of Pyxis. Some of the meds are in a small med drawer on the countertop, and usually that would be inhalers, creams, lotions, eye drops, nasal sprays, birth control pills, or any medication brought from home or not regularly supplied by the hospital. So if it's not in Pyxis or if it's grayed out of Pyxis, that usually means that it's in the patient drawer. Since you have to take the computer on wheels with you to pass meds, and they are not stored in the patient rooms like they are on a med-surg unit because it's a safety hazard. It may be easier just to bring it into the med room and get everything organized there. That's usually the best way to handle things. Always sanitize the top surface with a disinfecting wipe, whatever wipe they're currently using, and please use gloves. You don't want to expose your hands to all those chemicals, and you're going to do that between each med pass because that computer on wheels is traveling all over the place. So it's just really part of infection control to just wipe that down, wipe off the mouse and the computer keyboard really quick too. So that's your work area for passing meds. And there's also an area of the counter in the med room that's called the med prep area. So if we ever have to draw up any IM or sub-Q meds, we would do it in there. And again, we're cleaning that area out too before and after use, just because of infection control. There are a lot of lounges, several lounges on the unit, not a lot, but a few on the unit where groups may be held or where patients are encouraged to be out of room and socialized. Be sure to check all of them if you can't find your patient. So just because your patient isn't in their room, don't panic and wonder where they are. You have to look around first. But if you can't find them, let the staff instructor know immediately because everyone will drop everything and help you find your patient. Occasionally, a few of the doctors take the patient kind of off the unit behind locked doors and you don't have a badge reader to get there, but I will let you through or the staff will let you through so that you can visualize your patient. When we're doing those 15-minute checks, we have to visualize the patient. It's just so important. So if you can't find your patient, don't panic. Look around first, but let somebody know as soon as you can. And again, the other thing to consider when you're using any of those rooms to meet with your patient is don't let yourself get backed into a corner. Be sure you can easily leave the room, that the patient can't back you into a corner and prevent you from leaving. There's a few whiteboards on the unit that contains helpful information. One's located across from the nurse's station and has a list of all the group therapy sessions for the day. And possibly, sometimes they have the list of the patients that are invited to attend. It just depends on which activities therapist is on that day. So names may or may not be up there. If you don't see your patient's name, just check with the group leader before you encourage your patient to go to group. Yes, it's a great thing to go to group, but if your patient hasn't been assessed yet by the group leader before they go, then they may not be very happy that you've told your patient to go to group or encouraged them to go to group when they haven't actually assessed them first, especially if you have a new admission. But you can tell the activities therapist that you think your patient is appropriate for group, like they're verbal, they're able to express their thoughts and feelings. They're not overly, behaviorally disruptive or manic or overly stimulated, that type of thing. So they certainly may look to you for guidance as far as, do you think your patient's appropriate for group? But just be careful of that. The other board is near the kitchen, and it's a list of the names of the staff member assigned to each patient for that shift and their pocket phone numbers. So in case you have something really important to tell your nurse, but you can't find your nurse anywhere, then you can at least dial there. You have to go into the nurse's station and find a phone and then just dial their phone number, and then you can talk to the nurse, figure out where they are, or just tell them the information that you need to tell them. The clean utility room is our designated area to do charting and keep your supplies while you're out on the unit interacting with your patient. Just remember to keep the door closed at all times, even when you're in there charting. But of course, when you leave the room, make sure that that door is closed. You don't want patients, if you leave it ajar when you're in there, a patient might just pop in there, and then all of a sudden the patient is by the door and you're by the window and you can't perhaps get past them. So you just don't ever want to do that. And there's 4 computers on wheels in there usually for you guys to use during the day. Keep your clipboards, your stethoscopes there. Don't carry them with you on the unit, except obviously you have to take your stethoscope with you to get your blood pressure or apical pulse, but just return it to that room as soon as possible. You can carry a paper from your clipboard or papers into a patient's room, just not the entire clipboard. You may also have a pen with black ink in your pocket, and please only have black ink. So an example is when you're doing the 15-minute check sheet on the real clipboard. You don't want to do, I had a student once do many different colors of ink, green, red, blue. You can't do that because that is part of their permanent record, and it all has to be in black ink. Don't keep snacks or drinks in the clean utility room because it is a clean utility room. And actually, staff will be popping in and out of there during the day too to get different supplies. So kind of be aware of that. Even though that's our designated place for charting, it still is a clean utility room. So we have to be aware of that. There is a space on top of a file cabinet in the back of the nurse's station where you can put your coffee or water or anything that you bring to drink. And snacks can be kept in the staff lounge with your other belongings. But actually, I didn't say this on the PowerPoint, but I usually have a little basket of granola bars and things like that, cereal bars that I also put on top of that file cabinet in the back of the nurse's station. So if you're starving, you can run back there and have a quick snack and drink some fluids. Trust me, I will not let you starve or get dehydrated during clinical, because a starving, dehydrated student is not going to be a student that's functioning at their very best. So that's my philosophy. I hope this information's been helpful and will make the actual tour and orientation go more smoothly. Please have a list of questions for me if there's anything unclear in this presentation. Good luck. Have a great rotation. I am very happy to help you, and I look forward to working with each and every one of you.